Assalamu alaikum. I'm honored to be here speaking in front of such an experienced audience. I was asked to speak about cardiac amyloid imaging and also touch on cardiac sarcoidosis imaging in nuclear medicine, which themselves both are pretty big topics. I try to squeeze them in the limited time I have. So I know I'll be reminded to finish in time. So I'm going to talk about imaging of amyloid using DPD, technetium DPD scintigraphy. I'm going to break my talk into a brief overview of amyloid. Then I'm going to talk about a literature available and how DPD fits into the patient management, and look at a couple of cases according to the visual score. So as we know that amyloid is a fibrous proteinaceous deposits which are insoluble, and they have characteristics specific to them on microscopy. When they accumulate extracellularly or intracellularly in organs and give a systemic clinical disorder, it's called amyloidosis. Now, amyloid is classified according to the protein fibrils it forms. Now, the amyloidoses are referred with a capital A for amyloid, and then the abbreviation of the fibril protein next to it. That's how they classify it. So AL amyloidosis is the amyloid light chain, which is what you get in myelomas, and this was previously called primary systemic. Then there are the ATTR, and then there is amyloid associated. Those are the types of, that is the type of amyloidosis you get in chronic inflammatory disorders. Now, cardiac amyloidosis. This is, in most parts of the world, it is the commonest cause of restrictive cardiomyopathy, and most forms of amyloidosis can involve the heart, but the two most common forms are the AL amyloidosis and TTR, or transthyretin related amyloidosis, and these are the two I'm going to be mainly talking about today. So what happens when somebody has amyloidotic cardiomyopathy? Clinically, they can have symptoms of fatigue, dyspnea, fluid retention, pleuropericardial effusion. When the amyloid accumulates in the heart, it can cause stiffness, which gives diastolic dysfunction and arrhythmias, and heart failure with preserved ejection fraction. Why is it important to differentiate which type of amyloid is responsible for the affecting the heart? Because the treatment is different. AL is treated with chemotherapy and bone marrow transplant, and ATTR has got medical management with different drugs. Now, how do you diagnose it? The definitive diagnosis is obviously with endomyocardial biopsy. Also use tests like echocardiography and cardiac MRI. And I'm just not going to go into details about any of these. Just going to stick to our topic for today. Now, technetium DPD is the only non-invasive modality that can identify ATTR type cardiac amyloidosis with high specificity, and then can avoid unnecessary biopsies and help patient management. Now, a little bit of review of the literature. Pergini in 2005 did a pilot study looking at the diagnostic accuracy of technetium DPD. The reference standard was histology. They looked at 25 patients, 15 with ATTR and 10 with AL. Their conclusion was that the accuracy of differentiating between ATTR versus AL was 100%. He also described these scoring criteria, which is this visual score guide we use to report these scans. This was extended by Rabezi and all, and they looked at 45 ATTR patients and 34 AL patients. Now, their study confirmed that DPD is useful for differentiating between ATTR and AL amyloidosis related cardiomyopathy. But their diagnostic accuracy was lower than previously reported due to they found that 1/3 of patients with AL will also have uptake on scintigraphy. A bigger study by Hajra and all showed that 158 patients with clinical cardiomyopathy with ATTR had 100% positive scans, and the median grade of uptake was grade 2. 13 further without clinical cardiac amyloidosis had positive studies. 51% of AL with clinical cardiac amyloidosis had a positive scan, but with the median intensity of grade 1. So what is perigenic grading, or the visual scoring system we use in when we report amyloid scans? Grade 0 is there's no cardiac uptake, but there is normal bone uptake. Grade 1 is when the cardiac uptake is less than bone. Grade 2 is moderate cardiac uptake, which is greater than bone, but the bone uptake is attenuated. Grade 3 is intense cardiac uptake, with mild absent bone uptake. So a few cases with the examples. Grade 0 is, you can see there is no uptake in the heart. I'm not sure how, but there is normal bone uptake. So this would be grade 0, a negative study. Another example, we would tend to do SPECT CT in these patients to see if there's anything on anything at all on the SPECT CT images in the myocardium to confirm they are negative. Then grade 1 is when there is mild cardiac uptake, but the uptake is less than in the bones. Now, these, you can see this faint uptake in the heart. So all these patients would have a SPECT CT, and then you can see on SPECT CT that there is myocardial uptake. So these will fall in grade 1. Got some example of grade 2 as well. You can see there's moderate cardiac uptake, and the bones are looking attenuated. So heart uptake is more than the bones. So the tip to differentiate between grade 2 and 3 is that if you can still count ribs and vertebrae, it would fall in 2. But long bones are more difficult to see, and they may be absent. So as I said, if you compare, you can see the vertebrae and ribs in this one, and in grade 3, the ribs and vertebrae cannot be counted easily. So the grading, in a summary, you can see from grade 0 to 3, increasing uptake in the heart while reduced uptake in the bones. So a consensus was required to decide to use these in diagnosis of cardiac amyloid. So specialist centers in the US, France, Italy, Netherlands, and UK in 2014 looked at patients being referred to them. They had 1498 patients referred to them. Of them, 1217 were suspected to have cardiac amyloidosis. The question they were looking at: can bone scintigraphy be used to diagnose ATTR amyloid cardiomyopathy without using a biopsy, but using other imaging modalities and lab data? They looked at 374 patients who had the endomyocardial biopsy. 261 had ATTR, 62 had AL. 4 other types of amyloid cardiomyopathy, 47 had no amyloid deposits on biopsy. They found that 99% sensitivity for ATTR, that from grade 1 to 3, they had positive scans. But the specificity was 68%. That is mainly because AL type amyloid cardiac myopathy does also take up DPD. Now, if grade 2 and 3, we just looked at grade 2 and 3, the specificity rose to 87%, but the sensitivity reduced to 91%. There was only one patient with ATTR where the endomyocardial biopsy had a negative scan. When they looked at that, the biopsy, they had very few scattered deposits of amyloid, and even the interventricular septum thickness was just, it wasn't very thick, it was 10 millimeters. So specificity rises to almost 100%. So it becomes 100% specific for ATTR if you exclude patients with monoclonal proteins in the serum or urine. So the consensus they reached was that in a patient with clinical features of cardiac amyloidosis, as heart failure, syncope, arrhythmias, if they have a positive echo or a cardiac MRI, and they don't have any monoclonal proteins either in the serum or urine, and they have a scan which is grade 2 or 3, it is reliably diagnostic of ATTR. You don't need a biopsy. So the tracers which were developed for bone scintigraphy are commonly used. Most studied one is DPD. And I think that's not approved in the US, so they use technetium PYP. HMDP is less literature, but is also being used. The mechanism of action, it's thought it binds to calcium dependent mechanism. There might be microcalcification in the amyloid deposits. So how do we do the scan? We give it 700 megabecquerel. Imaging time, it's as we know in nuclear medicine, there are different protocols in different departments, but generally it's recommended 2.5 hours, 3 hours post-injection. How we did things in my previous hospital was that we would, after the whole body image, a consultant would review the images and decide which area needs to have a SPECT CT. Most of the time it was the thorax. Sometimes we would include the abdo-pelvis as well. The total radiation dose is 6.8 millisievert, of which the CT of the thorax contributes 1.2, and the radiopharmaceutical dose is 5.6 millisieverts. So when you report these scans, how do you report them? You look firstly at the heart. Is there cardiac uptake? Yes, no. Then if it's not, you do a SPECT CT. Is it truly negative? You adjust the grayscale. What's important to look at is it is actually myocardial uptake rather than blood pool in the ventricles itself. Then can comment on distribution. Look at the bones for the visual scoring. And if there's any incidental finding on the bone scans, obviously you're going to flag that up. Now, just a few points from the ASNC and A&M cardiac amyloidosis practical points. So when reporting this suggests that if you get a score of 0, you can just say it's not suggestive of amyloid disease. If it's grade 2 and 3, you can say strongly suggestive. Visual score of 1 is equivocal. You have to interpret these results in context of prior evaluation. If somebody is echo and cardiac MRI are positive, a strong clinical suspicion, even if the scan is negative, then you would recommend myocardial biopsy. Meaning is that if it's a negative scan, it doesn't 100% exclude cardiac amyloid disease. It's also important to exclude a monoclonal process in the serum and urine, irrespective of scan results. Now, equivocal results, even positive, could represent AL amyloid or early ATTR cardiac disease. So, summary, it's a useful non-invasive method of assessing for presence of cardiac amyloid. However, negative study does not exclude cardiac amyloid. You should look at SPECT CT for subtle grade 1 effects of soft tissue uptake. Talked about the Perugini grading, cardiac uptake versus bone uptake. DPD alone cannot be used to differentiate between AL and ATTR or other types of amyloid. But if a patient has grade 2 or 3 uptake, has a diagnosis of ATTR is likely in the presence of a positive echo, MRI, and absence of monoclonal proteins. This may have a role in early detection of cardiac involvement in variant ATTR that is preclinical, that is in screening, which may allow alteration in the management early. So I've tried to summarize cardiac sarcoidosis. It's a big topic, and just talk very briefly about it. It's a granulomatous condition. Sarcoidosis, as we know, is high incidence in women in Japan, Africa, Afro-Caribbean communities. It affects the lung and lymph nodes and other organs. About 2 to 5% estimated to have cardiac involvement, but up to 25% at postmortem have been found to have cardiac involvement, patients with sarcoid. Now, cardiac sarcoid, it's silent, conduction defects and ventricular arrhythmia. A patient can have those, can present with congestive heart failure, they can have chest pain, they can have sudden death too, unfortunately. Pathology is, as we know, it's an inflammatory process in the heart. It can give scarring. The areas primarily involved are the interventricular septum, posterior parts of the ventricle, and anterior left ventricle. The definitive diagnosis is a biopsy, which shows non-caseating granulomas. Steroids and other immunosuppressants are the treatment, and some patients may need cardiac-specific treatments like devices, ICD, etc. A little bit about the imaging. CT, it's very non-specific, you can hardly see anything. Rarely, maybe you can see in advanced cardiac disease, only a bit of thinning. but there you can see extra cardiac manifestations in the lungs and lymph nodes, etc. MRI is the modality of choice, though it's non-specific. Pattern disci, which are characteristic but obviously not always present, are late gadolinium enhancement, nodular mid-wall T2 hyperintense foci, and areas of myocardial thickening. Echo, you can get a wide range of changes from diastolic dysfunction to focal thickening and scarring. FDG is being used, and there is FDG-avid disease in areas of heterogeneous myocardial thickening. It's being used in detection as well as treatment response in cardiac sarcoidosis. FDG has been found highly sensitive for the diagnosis of cardiac sarcoidosis. A systemic review and meta-analysis showed sensitivity of 89% and specificity of 78% respectively. So the difference in imaging for cardiac amyloid compared to the other FDG PET CTs we do is the patient preparation, because the myocardium uses glucose for its metabolism. We need to suppress that to be able to look at the inflammation in the heart. So there are 3 ways it's done. I'm more familiar with the first 2, but I've read that in the literature that some people do give IV unfractionated heparin to reduce glucose uptake by the heart. Most of the time we ask for prolonged fast. 18 hours or more is considered ideal. In the fasting states, the heart starts to take up lipids for metabolism, so hence it's not going to take glucose. Heavily restrict carbohydrates from the diet in the 24 hours before the scan, and use a high-fat diet. So there'll be increased FDG uptake with inflammation.
Sorry, we are running short of time, ma'am. Please sum up.
I'm just going to summarize that. So you can combine it with perfusion imaging. So this is how it's done. You can inject, wait 90 minutes. Different departments have different protocols. Some also combine, many are combined with perfusion assessment. You can see in the first, this is a well-prepared patient. There's no myocardial uptake. This one has got diffuse uptake, so poor patient preparation. If there's focal uptake, suspicious for cardiac inflammation, obviously you'll compare with MRI. If you're doing perfusion, then you will compare the perfusion imaging with the FDG imaging. You will see if there are any areas of reduced perfusion, if there is focal uptake, then that will be active inflammation. But if there is no uptake, even then it's likely to be fibrosis. So same couple of examples. You can see multiple focal areas uptake in the myocardium. So you report them as focal uptake. Diffuse can be poor preparation or no uptake. So this is a patient, this is the most recent scan I found, is 54-year-old and diagnosed with cardiac sarcoidosis on this PET, started on steroids and methotrexate, and then her follow-up scan in June, you can see there's no myocardial uptake. So PET assists in diagnosis, gives prognostic information, can also tell us about extra cardiac findings. It's being used in response monitoring as well. I'd like to thank some of my colleagues, current and previous, to help me get some of these images. Thank you for listening.